In this video, we're going to take canter through the treatment options for snoring and obstructive sleep apnea. So we'll start with what you're most typically here for, which are custom adjustable MRDs. Now, these are the preferred option for snoring, and they do move up to being effective for mild, perhaps moderate, sometimes even severe obstructive sleep apnea, but they're typically thought of as the solution, the first-line therapy for snoring, antisocial snoring. And they work by advancing the lower jaw, moving the tongue forward, and tensioning the soft palate. They mechanically hold open the airway. They are, when compared to PPAP, which we'll come to in a minute, considered to be passive, as in they allow the patient to breathe for themselves. So ideally, we're talking ideal here, and the mandibular repositioning device would be adjustable, would be minimal in bulk, would be robust, it would permit lateral movement, it would be inexpensive, and it wouldn't produce an orthodontic effect, and it would be easy to fit and easy to adjust. Wish list. And I'm talking about custom adjustable devices, not OTC, not boil and bite, not things bought online. So move on. As I hinted at, I've touched this. Now, this is called positive airway pressure, or PPAP. So this pneumatically splints open the airway. Now, it works by forcing air pressure via a mask into the patient's nose, sometimes their nose and their mouth together. And now it's air pressure, it's not oxygen. Sometimes people make that mistake. Now, full face is a term that's used to describe a mask that covers the nose and the mouth. It doesn't normally cover the patient's whole face, but you can get that. But a full face is the term for nose and mouth. Nasal, typically, as you'd imagine, just covers the nose. You can get an oral positive airway pressure, but that's unusual. Now, it is an arduous therapy. It is not sexy, and but it is considered the only therapy for severe OSA. Your physician will think of positive airway pressure therapy as the only treatment for obstructive sleep apnea. Now, long-term patient compliance is contentious, and it's related to disease severity. So if your patient is moderate to severe OSA and symptomatic, they may derive a significant benefit from using PPAP and then will comply with it. If they are not symptomatic and they are a snorer, they will not use PPAP at long term. It might make them quiet, but they're not going to live with it. It's hard work, this therapy. Humidification is sometimes added to avoid the drying effect of the pressurized air. Let's move on. So we're going to split surgery into soft and hard tissue. Now, the intention of soft tissue surgery, as it says, is to enhance the effect of an oral appliance, enhance the effect of positive airway pressure. It's not normally considered adequate on its own, and it really has a problem with identification of where the issue lies. So typically you'll hear of operations on the patient's nose. Well, that's not really going to help if the problem's in the oropharyngeal, hypopharyngeal area. It can be justified in terms of improving the patient's breathing when they're awake, but it's not going to actually help with what they came for. So surgery is routinely confined to the pharyngeal walls and the soft palate, and the term for that is a uvulopalatopharyngoplasty. Scrabble winning word. It's a UPPP or UVPPP is the acronym. I'll say it again, uvulopalatopharyngoplasty. And the techniques to perform that surgery consist of laser, radiofrequency ablation, implants perhaps, pillar implants they call them, or just a straightforward scalpel. So move on to maxillofacial surgery. Now, the intention here is to remove any need for any other therapy, but this is barbaric surgery. It will move forward both jaws and will fundamentally change the patient's appearance. It needs normally to have more need than just sleep. I say just. you're going to fundamentally change the patient's face. So if they have other problems, then yes, it can be justified. Let's look at the overall landscape then for the therapies, the appropriate therapies for obstructive sleep apnea. UPPP, blue box top left. As I say, that's the area for it. It takes away the uvula, the soft palate, perhaps the pharyngeal walls. Move to the green box, positive airway pressure, typically through the nose. Maxillofacial advancement, that's bringing both jaws forwards, opening the airway. You do get remodeling, and it doesn't always have the same long-term effect. And then a mandibular repositioning device is considered temporarily bringing the lower jaw forwards. And then the tracheotomy, just bypass the area altogether. But again, that's the last stay thing. So oral appliances have two markets, snoring and then moving into apnea. So what we're looking at here is that 34% of the adult population are thought of as snorers, and that's the market that this training, this boot camp is all about. Let's sum it up. So in this video, in this chapter, you will have seen and learnt why you don't fix someone's snoring symptomatically. You have become aware of obstructive sleep apnea and the needs for a medical assessment, or in the UK, you need to be trained to screen and recognise. And you will now understand the role of a sleep-trained dentist. We've covered some basic sleep acronyms and definitions, and we've just been through the treatment options. Two markets for MRDs, snoring and obstructive sleep apnea for the medically diagnosed patient.